Welcome to Health Live at Seniors Today. Dr. Sujal Shah is Director of Ophthalmology at the Reliance Foundation Hospital and Research Center, which is in Mumbai. After completing his MBBS, Dr. Shah completed his DO at Sankara Nethralaya, the famous Sankara Nethralaya in Chennai, and also completed his D&D in Ophthalmology. Then he pursued a fellowship in Refractive Surgery Techniques in Los Angeles, the Cleveland Clinic Foundation, and the Jules Stein Eye Institute in LA. He has a rich experience of over 20 years in the field of ophthalmology. Apart from his association with the Reliance Foundation Hospital, he's also a consultant ophthalmologist at the Samyak Drishti, the Vision Institute in Mumbai. Earlier, he's worked with the Lilavati Hospital, the Baba Bhatia General Hospital, Convest Jain Clinic, and Surya Eye Tech Super Speciality High Hospital, Aditya Jyoti Hospital, Divid Drishti Super Speciality Hospital. He started the Roshni Eye Bank and Tissue Processing Center at Lilavati and was in charge of the eye bank at Convest Jain Clinic and the Bhatia General Hospital, which is at Tardeo. He was on the advisory board of the Eye Bank Coordination Research Center, the Central Eye Bank and Processing Center in Mumbai. He specializes in cornea, contact, and refractive surgery, and his list of specializations is so long that I could just go on and on. But we have here with us Dr. Sujal Shah, and we have requested him to speak with all of us here today about diabetic retinopathy, and of course, anything else which concerns seniors, and he is so close to what senior citizens are looking for these days. Thank you very much once again, Doctor, and over to you.
Thank you so much, Pradyumn. In fact, I apologize that I was late. I was late because we were with another VIP, a senior citizen incidentally, who had a different problem called age-related macular degeneration.
Right.
And we were doing some treatment for them. So good evening, everybody. And we are all here to talk about diabetes-related eye disease or diabetic retinopathy. So I think I'll skip some of this because I'm already late, but diabetes is a complex group of metabolic problems, and it can be insulin or non-insulin dependent diabetes. So diabetes actually will cause macrovascular or large vessel and microvascular or small vessel problems in different parts of the body. So it can affect almost any part of the body. Today we are discussing the eye. And why it is important to know this is that very often when proliferative changes, I'll show you what that means later in the presentation. But once such changes start in the eye, generally the kidneys are also involved around the same time. So just to give you an idea about the extent of the problem, India has approximately 7 million diabetics. It is predicted to touch 125 in the next 20 years. So approximately 1 in 5 adults have diabetes, and diabetic retinopathy is an important cause of visual impairment in diabetics. We'll go over these few points. So the prevalence of this is 12.5% of diabetics, and 4% of this, that is 1/3 of them, have severe, that is vision-threatening diabetic retinopathy or VTDR. And the risk factors of this are the duration of diabetes, or how long you've had diabetes, how poor or how good your control is, concurrent problems like hypertension, nephropathy or kidney problems, obesity and hyperlipidemia, smoking, and or pregnancy. So these are the features. So let's see how the microangiopathy starts. You have loss of some of the the cells in the periphery of the blood vessels. That starts making the cell wall weak, and then plasma leaks from that, and that gives rise to retinal edema. And it can also give these kind of cholesterol deposits, so called hard exudates, in a succinate pattern. Sometimes, if there is no leakage, but the capillary wall is weak, you can have a bulging of that, which is called as a microaneurysm, and it can sometimes cause leakages or intraretinal hemorrhages. So these are the and basement membrane thickening causes endothelial damage, Deformed RBCs and platelet stickiness and aggregation can cause a microvascular occlusion or a blockage in the small blood vessels. Therefore, there is hypoxia. Hypoxia means there's less oxygen supply through the blood to parts of the retina. And hypoxic retina will secrete something called as a vascular endothelial growth factor. And that will stimulate the growth of new blood vessels. As you can see here, these are some new, I'll show you better pictures of this later. You're seeing some of these new blood vessels in the back of the eye, that is the retina, and some in the front also. It's a small picture, I apologize for that. So based on severity, you have two kinds. One is proliferative or non-proliferative. Proliferative means new blood vessels are forming. So till new blood vessels don't form, it is called as non-proliferative. Even the non-proliferative can be mild, moderate, severe, or very severe. And it can be associated with something called as CSME or clinically significant macular edema. So this is an example of mild retinopathy. This is a normal macula, which is the center of the retina, and a normal optic nerve or disc. Here you're seeing some areas of leakages, cotton wool spots, these are called. Then there are some hemorrhages here, some outpouching of blood vessels called microaneurysms, mild NPDR. Moderate means these increase, you're seeing some saculations in the blood vessels, there is bleeding of vessels here. You are seeing areas of dropout. On angiograms, you can see there is ischemia or lack of blood flow. You can also see larger yellow spots called cotton wool spots. See, for example, this is a cotton wool spot. So this is mild to moderate, but still background. There is no new blood vessel formation yet. So this is very severe, but still non-proliferative. So you can see the same changes are here, but they are a lot more extensive. Blood flow is still intact. There is no complete blockage, but you can see how the vessel is tortuous. Probably has concurrent hypertension also. There are more hemorrhages. There are more of these cotton wool spots and exudates. Intraretinal hemorrhages here. Now, let's see what is clinically significant macular edema, because that can affect. See, till what is nice to know is that in all of this, till the center of the retina is relatively uninvolved, there is no swelling here, vision is maintained. So until a regular examination, routine examination is done, or something like this cannot be detected only. When you have clinically significant macular edema or CSME, these changes are coming in the center, and the center part of the macula, what we saw earlier, gets edema or thickening, and that is where the quality or the quantity of vision starts decreasing. The next stage is when new blood vessels form, as you can see here. This is a whole bunch of new blood vessels. Here also new blood vessels are forming on the optic nerve. There is some new blood vessel formation here also. Why these new blood vessels are important is that these are very thin and fragile new blood vessels. So any kind of minor shock or trauma can cause them to rupture, and then you can get a hemorrhage or bleeding inside the eye that can affect vision. So your reasons for affection of vision are either clinically significant macular edema or hemorrhages like this. This is where, so now you're seeing that there is a hemorrhage here, but still the center is clear. So it is possible that this patient's vision is still maintained till the hemorrhage crosses the center and affects the vision, because the blood is obstructing the field of the visual axis. Now, when new blood vessels form, along with them, there can also be something called as a fibrous proliferation. And as fibrous proliferation contracts, it can cause parts of the retina to get lifted. So you will get something called as a tractional retinal detachment. To make it simple for you, traction means when something is pulling. Okay, so a fibrous band is pulling on the retina, and that pull is causing the retina to detach. So you're seeing this entire area from here to here. These are new blood vessels and some fibrous proliferation. But in this much area, the retina is detached in the upper left part. Here there is new blood vessels formation in the front part of the eye called the iris, rubeosus iridis. This will cause a problem called as neovascular glaucoma. Glaucoma means very high pressure in the eye. And if there is very high pressure, it will affect the nerve of the eye and you can lose vision from affection of the nerve also. So what are the reasons for vision loss? Non-clearing vitreous hemorrhage, neovascular glaucoma, tractional detachment, macular ischemia or loss of blood flow to the macula, and clinically significant macular edema. How do you prevent such complications? So like we saw earlier, many of these changes, till you're getting a hemorrhage or macular edema, your vision is maintained. So early detection needs to be done. So the best thing to do is routine screening of the retina by dilation, where you go to the eye doctor, he puts some drops in the eye, looks at the back of the eye, and without needing an angiogram, you can easily see the back portion of the eye called the retina, and you can screen for all these problems. So if you do this regularly, we can pick up problems in a very early stage, and we can start early appropriate treatment so that the things don't progress and vision can be maintained. So you can be a diabetic for all your life, but if you go for regular exams and try to control your diabetes, you can still maintain good vision. For mild and moderate non-proliferative retinopathy, there is really no treatment from our point of view. You need good control of your sugar and you need good control of all your other associated things like hypertension, anemia, diabetes, renal problems, cholesterol, and other things. Very severe non-proliferative retinopathy needs very close follow by the ophthalmologist. Clinically significant macular edema and of course proliferative retinopathy needs close follow-up. So now in the early stages, severe and severe non-proliferative retinopathy, we can do laser treatment to minimize the risk of hemorrhage or vision loss. In proliferative retinopathy also, in the early stages, depending on the judgment of the doctor, you can do laser to prevent vision loss because it reduces the oxygen load on the retina and prevents the formation of new blood vessels. So for all diabetics, we should actually have a minimum screening of once a year. It's important to know that generally these changes start after 5 years of onset of diabetes. So if you know exactly when your diabetes started, then 5 years, at least every year, after the first 5 years are over, you should get it checked. But very often when you are detected, you don't know how long the diabetes has been there. So I think once you're diagnosed as diabetes, you need to be checked once a year at least. If you have moderate to severe disease, I think screening once in 6 months also is not a bad idea. Now, very often the screening is done by the endocrinologist because many diabetes specialists, so nowadays many clinics, even in fact, we are doing a pilot experiment with this, where a screening exam with the fundus camera is done. And that is an AI-based tool that helps to screen proliferative versus non-proliferative or referable versus non-referable diabetic retinopathy. If any visual symptoms like decreased vision, floaters, pain in the eye, redness, others are detected, then a referral to an ophthalmologist is required. So this is how normal vision will look, okay? And if you have diabetes and you've lost function in parts of the retina, due to the disease itself or due to laser treatment or patchy laser treatment, sometimes your vision can become defective like this. This is an example of a normal retina. Again, this is a normal retina. And this we saw earlier are the mild, and early changes starting. This is moderate, mild to moderate disease. This is clinically significant macular edema where the center of the retina got involved. This is a specific thing called cercirate retinopathy where actually is involving the macula in the circle, but the center is still spared. So these are different stages, background to mild to moderate, and these become more and more severe. If you have diabetes along with hypertension, sometimes you can have something called as central retinal vein occlusion, where you can get something like you get a heart attack, you can get a minor attack in the eye and lose vision from that. Again, various examples of the same. So if you have clinically significant macular edema or proliferative diabetic retinopathy like this, in addition to laser treatment, we can also give anti-VEGF injections. VEGF means anti-vascular endothelial growth factor that helps us to shrink these new blood vessels and prevent the risk of hemorrhage in the eye. In very advanced stages with long-standing vitreous hemorrhage or tractional retinal detachment or fibrovascular proliferation, one may need surgery. All basically examples of this. So in a stage like this, when there's a tractional retinal detachment, these membranes will not come out without surgery. So you will need a combination of laser, injections, and surgery at this stage. So I think, Mr. Maheshwari, I have come actually to the end of this thing, and if we have time and if people have any questions, I'm more than happy to answer them.
Yeah, we have some time. Can I? Some questions have come in already.
Please.
Doctor, if you can put off the screen share.
Yeah, I'll do that.
So, doctor's presentation and this entire video will be there on our website on Monday, by Monday evening. So those of you who, missed some part of it or not taken notes, etc., don't worry. It will be there on seniorstoday.in along with the takeaways, as you know, which are written by a medical practitioner. So, Doctor, we have quite a few questions that have come in already.
Sure.
The first one is from Sharda Parvale, who's how do diabetics take care of their eyes and what happens to retina in diabetes? I think you've already addressed this. A question from Mr. Akore Mrityunjay Kumar. He's 72. He has BP but no diabetes. What precautions should he take further from diabetes? I guess we can't answer that, but what is the thing?
The thing is, that though I have not covered hypertensive retinopathy, very often you can get similar changes in hypertensive retinopathy also. So as a layperson, what care you need to take is see your doctor regularly and ensure that you're keeping your blood pressure under proper control. So if you have high BP for a long time, you can get changes in the retina from BP or hypertension also, like you're getting changes in diabetes. So the simple thing is, whatever normal exercise, at least walking, if you can do half an hour of walking is recommended for diabetics. Follow a sensible diet that you can maintain. Take your medications regularly and see your doctor regularly for your diabetes checkup.
Doctor, I know this is not a question which concerns the eyes, but in a season like this, where it's been raining in Mumbai for the last 10 days, what kind of exercise would you recommend to somebody who has to?
So for diabetics, during COVID, we would all recommend walking at home. My own parents, both of them are diabetics, so they would walk up and down the house and try to get in at least 20-25 minutes twice a day. That is one exercise. Some people have stationary bikes at home or a walker at home. But if everybody doesn't have access to all of that, you can walk in the corridor, you can walk in your building in the parking space if it's a covered parking, or you can walk at home.
Absolutely. But walk one must. We have a question from Mr. Anil Singh. The question is, can a diabetic person donate eyes after death?
Absolutely. Absolutely. So diabetes affects most of the parts, or means it basically affects the retina and the nerve in the eye. It can affect the iris. In donation, the part of the eye that is used is called the cornea, or the transparent front part of the eye. And that can certainly be donated, because that in diabetics will generally be healthy.
Right. We have an anonymous attendee who asks, he's 65, he or she is 65. The question is new blood vessels, do they form normally the diabetic? Do they form normally the diabetic?
No. New blood vessels do not form normally in a well-controlled diabetic. Okay, they will form in a diabetic whose sugars are uncontrolled for a long time. They are forming because of hypoxic stress, because because of microvascular occlusions, part of the retina is ischemic, is having lack of blood flow, and this is kind of ischemic retina secretes vascular endothelial growth factor, like I mentioned earlier. And vascular endothelial growth factor stimulates the new vessel formation. So once it will not happen in a normal person or in a well-controlled diabetic.
Doctor, we have a question from Girija Ganesh, who asks, will renal failure affect the retina?
Renal failure per se will not affect the retina. The retina itself will not affect renal failure, but both happen concurrently. And so once you have proliferative retinopathy or new vessel formation in the retina, generally, as if we see this in the eye, we will recommend that the patient goes and sees a kidney doctor or a nephrologist, because the chances that he has kidney involvement are high. But that doesn't mean he will certainly have. He may get it in the near future. And renal failure is far away. So once you have proliferative retinopathy, you might have nephropathy, but you don't have renal failure right away.
Right. We have a question from Shamla Ravi. She has two questions. What is the gold standard test for diabetic retinopathy? And how effective is the intermittent fasting? How effective is intermittent fasting to arrest retinopathy?
So the gold standard test for detection, at least early detection of diabetic retinopathy, is a dilated retinal test, which is a very simple, very clean, easily available clinical test that any eye doctor can do actually. And increasingly, we are trying, different people, different teams all over the world are trying to develop tools where we can do large-scale screening of diabetics, which is AI-based, but that is not out yet. So in the absence of that, regular examinations by your eye doctor once in a year is good enough. The second thing about intermittent fasting, actually, I am no expert on intermittent fasting. I have really no idea. I am sure it is very effective. I have many friends and people known to me who are doing it and recommend it strongly, but I don't know how it works, and I don't know its effect specifically on diabetic retinopathy.
Right. Which have a question from Sunita Verma. Is, the very basic question, is retinopathy reversible?
So in the early stages, in very early stages, like mild to moderate retinopathy, it is reversible with good metabolic control of your diabetes. But once it becomes severe, non-proliferative or proliferative, then it is not going to reverse completely. But with medication, with laser treatment, and sometimes with injections, anti-VEGF injections, you can maintain it so that the disease doesn't get worse. Along with all the eye treatments that we do, it is important that you maintain your blood sugars. So you can't keep doing this treatment, and if your sugars remain uncontrolled, you cannot expect the disease will remain stable.
A similar question was also asked by Mr. Gyanchand Shukla, so I'm not asking that. It was 70. We have a question from Mr. Mahavir Hazare. He's 69 and he's taking medicines of BP and diabetes. His question is, how does one come to know about the fact that the cataract has started in the eyes?
Actually, you will know it basically only from a routine eye examination. if your vision is tested and somebody does a slit lamp examination to see whether you have a cataract or not. But if you're diabetic or hypertensive, it's a good idea to see your eye doctor once a year. You can go earlier if you feel that the vision is becoming blurry. If you sit at the same distance in front of the TV every day and you feel the vision is becoming less, if you drive at night or if you're facing any strong light and you're getting glare from that and you feel like turning your eyes away, if you feel that colors are not as bright as they used to be earlier, so any reason that you feel there is a affection in the quality of vision, you should go in for a test because cataracts are very common. In fact, in diabetics, one can often get cataracts earlier than normals.
Right. And doctor, what you're talking about eye checkups is checkups with not at the opticians as a lot of people do.
Absolutely right. You pointed out this very correctly. I think many people go in for an eye test to the opticians, but that is not the kind of eye test I'm talking about. And I'm sorry, I thank you for actually pointing this out. This is an eye test to be done by an ophthalmologist or an eye doctor who checks not only your vision, but also for cataracts, also the pressure of the eye, puts drops, dilates your eye, looks at the retina, looks at the nerve. So looks at complications of diabetes in the eye, and in addition to that, any other pathology that may be there in the eye. So I'm talking about a regular test with an eye specialist.
But getting an appointment with good eye specialists is so difficult these days. I've seen it how it is in Mumbai, and one could have to wait and wait and wait. But I'm not going to ask you to answer the question, but still. We have a question from Mr. P. Satyanarayan, who's running 76. He says, diabetes with control, taking BP tablet and Urimax. Sometimes vision is blurred for a fraction of seconds. Those specs are minus 1.30. I would like to know the reasons for blurring.
So if the blurring is intermittent, it's not there all the time, then it can be due to dry. So it is some cause that is coming and going. It could be dry eye. But in somebody who's diabetic and hypertensive, one should also rule out something called as a TIA or a transient ischemic attack. So if you're getting intermittent loss of blood flow to the nerve in the eye, you can also get attacks of blurring. So it is important. In fact, someone known to me 1 year ago had complained of a problem like this. I had examined the retina. I found this to be normal, but I asked him to see his cardiologist. He delayed going to the cardiologist and he came back 2 weeks later with an eye attack. He lost vision nearly completely in one eye because one of the major blood vessels was occluded. So if you're getting intermittent attacks of, now when you say loss of vision, no, it has to be like a blackout or a black curtain in front of the eye, not things out of focus, because out of focus can be related to the spectacle number. So if things become blurry as in out of focus, that is probably a less serious concern than in things becoming washed out or appearing, as if everything becomes a blackout and then comes back in a few minutes or seconds.
Right. We have a couple of questions on glaucoma, doctor. If you don't mind,
take
another 5-7 minutes.
Sure.
We have a question from Mr. Satish Kalia, who's 78. Stages of glaucoma. How can we check eye pressure at home, since doctor wants me to keep eye pressure low and below 21?
Nowadays we have portable devices that can check the pressure. In fact, in the US, many people keep these devices and they are able to check the pressure at home. It's a very quick, non-invasive test. But these machines, to my best knowledge, are at least upwards of 3 lakhs or so. So one can invest in one if one needs to. Otherwise, it's best to go and see the doctor regularly. Because once the pressure is, suppose high pressure is detected, what is the next step? You will still need to ask your doctor only. So it might be a good idea to see the doctor than to keep such a device at home.
Right. We have a question from Hannah. She asks, she says, I'm a pre-glaucoma patient. Since 13 years, laser treatment was unsuccessful, so my ophthalmologist suggested eye drops to be used permanently. I use Dotas T every once once a year. Touch wood, my vision is good, and so is the eye pressure and control. I do eye checkup, including perimetry test. All is fine so far. Do I still have to do an eye structure test?
What do you mean by an eye structure test? I'm not sure what she is.
Yeah,
Is that an OCT? Because to monitor glaucoma, you need to do two different tests. A perimetry test is a subjective test of your side vision, where you look into a machine and there is a light flashing in front of the eye, and you have to respond whenever you see the light flash, and it quantifies how much is your side vision. This is an indirect test of the health of the optic nerve in the eye. There is also, if you're calling a structure test, like an OCT or an optical coherence tomography test of the optic nerve. And that looks at the nerve fiber layer in the eye, and that actually is the direct test of the nerve. Glaucoma affects basically the nerve of the eye. So we generally recommend perimetry and OCT, or an objective and a subjective test, in addition to having the pressure checked.
It is OCT, she says.
Okay.
We have another question, Doctor, from Katie Dadanchi. She says, Doctor, my husband, 78, has had cataract surgery in January this year. The doctor informed him that he has dry macular degeneration. Her question is, does dry macular degeneration always lead to wet macular degeneration, which then needs injections for a long time? Are there any tablets to control macular degeneration? And he is not diabetic.
So dry macular degeneration does not always become wet. Many people with dry macular degeneration, in fact, can go on years and years without it becoming wet macular degeneration. To prevent wet ARMD, one can take antioxidant tablets, and there are a lot of antioxidant tablets in the market now. Things that contain tablets that contain lutein and zeaxanthin, and nowadays people are also recommending tablets that contain saffron. So for I can't take any specific drug or tablet names in this, but there are a lot of antioxidant tablets in the market that can help with retinopathy, with ARMD.
Doctor, three last questions. One is from somebody, Mr. Hemant. He's not mentioned his age. He's had a cataract operation done 2 years back. The retinopathy was done before the cataract operation. Can the cataract operation be done twice? I am diabetic for 15 years. Diabetes is under control due to insulin injections.
A cataract operation generally does not need to be done twice. So the first time it is done, it is a well-done operation. There is no other trauma. There is no other risk factor in the eye. If the vision is good, one generally doesn't need to do a cataract operation a second time. But if for some reason there is any kind of complication, then the surgery can be repeated. Not for the cataract itself, because that is out, but for any complications that indicate the surgery.
Doctor, there have been 2-3 questions about exercises. What kind of exercises do you recommend? Is any yoga? Do you recommend pranayam for glaucoma, for general eyes care?
I from what I know from my yoga instructor, actually, they do not recommend any kind of kapalbhati or different kind, some of the pranayams for people with glaucoma, because it basically increases the intrathoracic pressure and intra-abdominal pressure, and even shavasana and things like this. As far as control of diabetes is concerned, I think they used to recommend a Vajrasan and Kapalabhati and other things. But these are all anecdotal answers. This is not evidence-based answer as to that, X number of people did this exercise, and in Y percentage of them, the sugars were controlled with or without medication, or lowering of the dose of medication. So it is hard to tell whether they are effective or not.
Right. Thank you very much. We've answered quite a few questions, Doctor, and it's always good to have doctors like yourself who are taking time out to address all the questions. As you can see, there are quite a few more questions that have come in, but I have not really addressed it. Mr. Rajiv Murthat, I know you are a regular person here, but your question was not about eyes, so I have not asked it over here, but it was about diabetes. But thank you very much, Doctor, for your session today. We've had a good 135 odd participants at this session, and we've completed 5 years, Dr. Shah, this year, and 5 years of dedicated service to the senior citizen community, and 4 years of the health webinar. We do it every Saturday at 5 o'clock without fail. Thank you very much. And we will be back once again for another session of Health Live at Seniors Today next Saturday at 5 p.m. Remember, tomorrow is the finale of Seniors Have Talent season 15, and the magazine, the latest issue of the magazine, where you have a special interview with Thalaiva Rajnikant that is there on our website, seniorstoday.in, and it's available free of cost. No conditions apply. Thank you very much, Dr. Shah, and thank you to the team at HN Reliance for facilitating this. Thank you very much.
Thank you, actually, for this opportunity, and thank you for conducting such nice webinars on a regular basis for the senior citizens for 5 years.
Thank you very much. Thank you.
Great. Take care.
Subscribe now and press the bell icon. Never miss an update.